Hello, digestible listeners, and welcome back to the podcast. I'm Staci, along with my sister and co-host Melissa. And here at the Digestible Podcast, we like to give you all the health and wellness information you need in an amount of time that your busy day can handle. And we make it easily digestible. And today, we were lucky enough to spend time with Dr. Amy Brode, who is amazing. And we definitely took it like next level, but easily digestible. Missy, tell us about Dr. Amy Brode.
Absolutely. So Dr. Amy Brode is a urologist with a subspecialty in menopause care, hormone management, and sexual health. She's based in Michigan. She graduated from Michigan State University College of Osteopathic Medicine. She is a North American Menopause Society certified doctor. She recently opened a private concierge practice called Balance Point Inclusive Wellness, and you can find her at thebalancepointwellness.com, and we'll put a link in the show notes. Fantastic, wasn't she, Staci?
She was so fun to talk to. We talked a little bit about menopause, menopause, and sexual dysfunction.
Yeah, sex drive, libido. I mean, you guys, this is, like Staci said, this is like next level sexual health. So we hope you listen in. I think everyone's going to have something to take away from today.
Enjoy.
Dr. Brode, welcome to the podcast.
Good afternoon. Thank you.
Thanks for being here. Could you tell us a little bit, before we get started with the questions, a little bit about your new practice?
So I have been doing general urology for about 20 years, and I recently shifted to a concierge practice where I'm focusing on menopause care, sexual health, and menopause management for men and women, or all genders. And it's really an approach where I can spend more time with patients and really get to know them and individualize care so that it's not that kind of cookie cutter care that often we're stuck with when we're in an insurance model. So I'm really excited. It's a new way to be able to help people and really get to know them better.
So important and so needed.
For sure. That's excellent.
Yeah.
Well, we're excited to have you because we have some really, relevant questions for a lot of people these days. So first of all, when hormone shifts are happening during perimenopause and menopause, because we've had an episode on what perimenopause and menopause is, but when we have the hormone shifts, what's happening?
And that's a big thing. And I know I heard your episode. You guys had a great episode about menopause, and it's such an important topic. And just as a little kind of refresher before I go into those details for people, perimenopause and menopause is confusing for a lot of people. And perimenopause is really the time period where things are starting to change. Menopause is technically really just a moment in time. Menopause is defined as 12 months without a period. After that is postmenopause. So really menopause is just like a moment in time. And the hormonal changes that happen in perimenopause can be happening for years and years, and a lot of people don't even realize it. And so those hormone changes can be very irregular, and that's part of why people don't recognize it. We see in the early time when you're perimenopausal, progesterone, we talk a lot about, the main hormones, progesterone, estrogen, testosterone. Progesterone is the one that really starts to decrease first. Okay. And so we see that in perimenopause, and that's where a lot of the treatments kind of target that. We see that starting to decrease. In that time period, that's when people may start noticing some irregularity in their cycles, maybe, a change in the timing. There's inconsistent ovulation, which is what causes the decrease in progesterone. And estrogen at that time is not consistent. It can be all over the place. And so sometimes when people think of menopause and they think of the symptoms being low estrogen, it's actually the inconsistency. They may get really high levels intermittently and then low levels. And so that's where people initially may just notice worsening premenstrual syndromes that they had before, or they may have more frequent periods, or the change in heavier or lighter periods. As you get closer to actually menopause in the later transition, that's when we start seeing what we consider the late transition to menopause or late perimenopause. That's when you have more consistent periods of time between a period. So what we call amenorrhea is not bleeding. So you may go over 60 days and you start having more of those prolonged periods of time without bleeding. That's when you're seeing a further decrease in the progesterone and you're seeing a more decrease in the estrogen. But again, it's that inconsistency.
Okay.
And that's kind of what you start to see in the perimenopause.
So it's a fluctuation. It's not like this decrease necessarily, although eventually it does decrease. and steady
Correct.
out. Okay.
Correct.
So
But
is
then
that
if
when
it's
like the mood swings happen? Like is
It
so like
can
the
be
up
a
and the
lot
down?
of this. Yes, it can be the changes in moods, the changes in sleep, all that stuff can be because you're getting this wacky, up and down, and your body just doesn't know what's going on. And so, it's a little maybe off topic, but when people think about the different treatments, that's why there's so many different options. And in perimenopause, the options that we choose may be different than once you're actually menopausal, because you're trying to regulate, not necessarily always trying to add back estrogen. It may not be the low estrogen. It may be the fluctuations that are causing the problems.
Oh, that makes
That's
so much
interesting.
sense. Okay.
Okay.
So it's not that like high estrogen gives you anxiety and low estrogen makes you not sleep. It's just that it's all of the fluctuations that throw everything off.
There is some of that where the specific highs and the lows have varying symptoms, but they're continuously changing. So it's the inconsistency in how your body's responding to a lot of that. So yes, some of those symptoms are from the high and from the low, but it's even more so just that change, that irregularity.
Okay. Because as someone who's in the post period, it's everyone's like, "Are you anxious? Are you moody? How's your sleep?" And I'm like, "I'm pretty fine because I just don't have any fluctuations, I guess."
And we're all individuals. So while menopause is such an important topic and there's so many benefits, everything is individualized. And, it's like when somebody will say to me, well, does everybody need to be on hormones? I'll almost never say everybody to anything, because just because there are these common symptoms or there are these things that we see, it doesn't mean these symptoms or, what Melissa feels is not what Staci feels, and vice versa. And so when we're looking at the big picture and we're individualizing, and that's part of why I'm doing my practice the way I am, is so that I have the time to learn the intricate details on people. You can say that, well, for most people, X, Y, Z, but for you, these things aren't bothering you. So we don't need to target that.
Yeah, it is sort of bizarre. And so I get together with my friends a lot and we talk about, are you on hormones yet? Or what are you doing? Do you need to be on hormones? So I'm on progesterone. I'm on progesterone and estrogen. And I take my progesterone at night. And I had a friend who was taking it in the morning and she was having trouble sleeping. So my friends and I are like, oh, just shift to the night. And she's like, oh, okay. So she doesn't take it in the morning. And then during the day, she has breakthrough bleeding, like big time, like crazy. Like she just got her full period in the car. It was awful. And we felt so bad. She goes back, I tried to switch to night and I bled over my car. And we're like, oh my God. So it's so hard it's good to share the stories, but you're right. Like everyone's different. I think I skipped mine once and I took it the next morning because I'd forgotten and nothing happened. So it's like crazy.
And there's adjustment times. So that's also where, having the time to explain that to people. So, where your friend maybe had this like crazy bleeding the one day. Well, if she stayed consistent with it though, it would probably even out and she'd be fine. But what happens is you make a change and then you have this crazy side effect or this crazy problem or this change. And it's like, oh no, I got to go back. That doesn't work for me. Well, it was, that was like a day or even a few days.
So she might have been fine after that, but that just...
Sometimes you have to just give it time, and that may not be for everybody, but generally there's an adjustment period for your body. And so, while something can happen from an acute change, you got to give it a little time to really see where it really settles.
Okay.
All right. And so you go through like this crazy perimenopausal time, then you're menopausal, and then you're post. And then when you're post, are there hormones? If you're not taking any hormones, is your body making any hormones? What's happening?
So really, you're not really making the estrogen and the progesterone and testosterone. We'll talk about that too. But, testosterone goes down as well. And so you're really, the ovaries are no longer making it. There is still some. It's not that there's zero, but it's not much, And again, our bodies adjust. And people's symptoms can last varying time periods. Some people, once they're postmenopausal over, a certain amount of years, they don't have symptoms anymore. Some people do. And so again, that's still where it's individualized and where we have to look at how long we keep somebody on the hormones. Some people that weren't put on them right away and now they still want to get on them. We talk about the timing hypothesis and when we can see the benefits versus risks of it. And so we, ideally we want people on within 10 years of their last period, but that's not set in stone. Again, it's still that individualizing.
Why is that?
So some of that came from, a lot of it came from the Women's Health Initiative, which was a study that was done. And that was the study that kind of scared everybody away from hormones. And I don't want to get too much into that. I know you guys actually talked about that before, but it said the increased risks and heart risks and breast cancer, all these things that really on later analysis of that same data really debunked isn't the right word, but really showed that wasn't accurate. But we see that's when we see the best benefits for women's heart health are within that 10 years, as well as the safety profile of using the hormones. And so that's really where we see the most benefit.
Okay. But 10 years is still not bad. That's not a short period of time.
And it doesn't necessarily mean that people can't stay on it longer, but ideally that's when we want to get people started. That's where we see the most data to show us safety and benefit.
Okay. And that's such a relief because honestly, like there's that New York Times article that came out recently that talks about all the health consequences of postmenopause, basically on women, all of the things that the reduction does. And it was a little uncomfortable to read it. It was just so many things like bone loss and cardiovascular disease risk and sleeplessness and hair loss and like little things and big things, like things that are like aesthetic and things that are like, so. And
that scare, where we saw this data that everyone has this fear of breast cancer. Actually, a lot of the data shows a decreased risk of breast cancer on estrogen. And so, some of these things that are risks are, I talk with people, what are the risks of not being on it, like you said, versus what are the risks of being on it? And sometimes people forget about that component of what's the risk of not being on hormones.
Right.
Yeah.
And that doesn't mean everybody needs to be on it. It means that we need to look at the big picture.
Okay. Absolutely. All right. Let's talk about something that I don't think gets discussed as much around menopause, but is very, very important. Sex drive.
Mm-hmm.
Why does the sex drive change? And is low libido always hormone related?
Again, I very rarely use always. So no, it's not always. But yes, so we have a decrease in testosterone as well, and estrogen and progesterone. So they all affect sex drive. It's also a time in life where a lot of people have changes at home, changes in, people who have significant others or children. That a lot of times is changing around those times. Jobs may be changing. It's very multifactorial. And we always have to look beyond just one thing. Okay. And that's, one of the things in this great, wonderful thing that we're seeing so much more awareness about hormones and menopause is also sometimes that people want to say the only solution to anything is hormones. That's part of it, but there's multiple factors. So with sex drive, yes, testosterone is part of it. And there's also, like I said, the relationship factors, the psychosocial factors, pain. When people have less estrogen vaginally, when we see what we call the genitourinary syndrome of menopause, and you're having pain or discomfort, that's going to affect your sex drive. Why are you going to want to have sex if it hurts?
Right.
And there's things that are promoters that make us want to be sexually active, and there's things that make us not want to, and it's a balance of those things.
If women are experiencing pain during sex, and I know that there's obviously like topical lubricants, but isn't there are vaginal estrogen creams usually helpful with that?
Absolutely. That's one of the few times where I almost say every single person should be on vaginal estrogen. Okay, so vaginal estrogen comes in creams, tablet suppository. It comes in actually a ring that can be changed, and that's going to help locally. That's not instead of systemic hormones. So when we talk about like patches or pills or gels or things like that for our other menopausal symptoms, that's not the same as local estrogen in the vagina and vulva. And so that is so important. Not only does it help with pain, discomfort, lubrication, it also helps with urinary symptoms as far as, urgency, frequency to urinate. There's estrogen receptors everywhere in that area, and our bodies love it and want it. And so if it were up to me, I would be putting people on vaginal estrogen It would be at the drugstore. There would not be a prescription, and everybody would be on it. It reduces the risk of recurrent UTIs. That's one of our best defenses against urinary tract infections.
Is it a daily treatment, or is it like a couple times a week, or how often do you have to use the vaginal estrogen?
It's usually twice a week. Okay. I generally start people on it every day for 2 weeks, just to get a little boost there. And then it's twice a week. One of the things some people don't like is the cream comes with like a little applicator. My thing I tell every single patient is throw that applicator out. It just gets gross. It's disgusting. You can't wash it. You can't clean it. It's easy enough to just put on your finger. You wipe it up inside the vagina, and then also wipe it all over the vulva. You want it on the clitoris, on the labia minora, the bigger lips, the smaller lips. You want that whole area loves estrogen. And so with the cream, I like that because you can really get the whole area.
And if you're already on a patch, you can still do the local, the cream, because it doesn't.
Absolutely.
Okay.
Absolutely. And while there are some patients who can't use systemic estrogen, most patients can use vaginal estrogen. So even patients who have breast cancer, other GU cancers, clotting problems, things like that, the rare people who really, really can't use systemic estrogen almost always can use vaginal estrogen because it's not getting absorbed into the rest of your body, which is why it's not treating those other symptoms, is because it's really staying local.
Okay, so that would address the pain during sex, among, sounds like a whole lot of other wonderful things it can do.
Right.
But that doesn't affect the libido. Libido is more like the testosterone levels, your estrogen levels, things like that.
Right.
Okay.
And then as far as the pain also, so while we have that vaginal estrogen, there is also vaginal, for some people, they need more than just estrogen. They need also vaginal testosterone, or DHEA is a product that we use that's like a precursor to testosterone that can be used vaginally as well. And you mentioned like the lubricants and moisturizers are great, but they're just like a topical treating the symptom. They're not really getting down to the root cause. And so those can be used in addition. There's also, when we talk about the pain, pelvic floor physical therapy. Huge. And a lot of people, I don't know why, I feel like physical therapy gets a bad rap. You know, people think their doctors send them to physical therapy when they don't know what else to do. That's another one. Like, send so many people to pelvic floor physical therapy because it helps with the discomfort, the pain. It can help with orgasm. It can help with the sensitivity. So it can help so many components of the sexual response and the pain, that it's such an important tool for women who are having trouble, and men. I send men to pelvic floor therapy too, but it's such an important tool for that. And then that affects libido also, because like I said, if you're having pain, well, you know, if this hurts, why do you want to do it?
Right. Now, two things. One, does the vaginal estrogen help with your libido?
Not so much directly, just because so little is being absorbed, but it can help with your sensation and orgasm and other parts of the sexual response.
Okay.
Not as much the libido.
So you're incentivized.
Yeah.
Right. You're a little more
but you're not necessarily feeling the,
Right.
And
extra urge.
And before I ask this question, thank you so much for being so candid. I think that women will say like, oh, I'm taking hormones, but no one really says like, well, I have this estrogen cream and I'm going to rub it all over the lips. And like, thank you for just being so candid, because I think women really need to hear this.
And you know what? People don't know their own anatomy. Like, we've grown up, I mean, you know, I think we're kind of all the same generation, but especially you go a little older. I mean, I see patients who are in their 80s, they have never looked at their own anatomy. They don't know their own anatomy. There's a, you know, and so I actually have a diagram that I'll give people to show them what I'm talking about. Because people also, like you said, they don't want to talk about it or they're embarrassed. And so I can say, put it by the clitoris, put it by the labia majora, minora, and the vulva. They don't even know what those words mean.
Wow. Yeah.
And so we need more education.
And more conversations. That's great.
Yeah.
But I had a friend years ago who I think was having pain with intercourse, and she did some sort of treatment. I feel like it was named after a famous artist. Is there like a Da Vinci or a Mona Lisa? Okay, there's something. Thank you. I can remember. What is that?
I'm like, what are you talking about? Yes, the Mona Lisa. That's a laser procedure.
Okay.
And that can be used for genital urinary syndrome and menopause, which is the decreased estrogen. It is. I mean, that there's some data to support it. It's less common, probably not as needed as some. You know, I think before we had better data on the safety of estrogen, some people who were afraid to use estrogen were going the route of doing the laser. I used to do those years ago. I haven't done them in years. And when I stopped, It wasn't because they weren't good. It was just where I was working, we didn't have one.
There's also wands too, like wands that you can buy.
Oh, the red light wands.
No, just it's like a massager that goes up in the vagina, and you can use it to like
and that's actually, there's interesting, data that people are starting to look into as far as even vibrators, and actually the benefit of vibrators for pain and for sexual dysfunction and the genital urinary syndrome of menopause, and that using a vibrator, not necessarily for sex, not for the orgasm or the pleasure, etc., but actually using it therapeutically. There's not enough yet for me to say, oh yeah, that definitely works. But there's definitely some promising data showing that, the vibration that we see using vibrators as a therapeutic tool, not just
like relaxes the muscles and the things that maybe
that's so
cramping or pain.
Data we have in other parts of the body as far as like pain receptors and stuff. And so they have, things that you can use, like even for kids, like that if you do vibration, it takes up the, it kind of confuses, so to speak, the receptor so that then you don't feel the pain. So it's kind of similar stuff like that they're looking at as far as using vibrators in different ways, and
it's fascinating.
And that also brings up, when we talk about libido and pain and all that's the other thing a lot of people don't like to talk about. We talk about sex. I don't even know what someone means when they say sex. Do they mean penis and vagina intercourse? Do they mean oral sex? Do they mean anal sex? Do they mean, all external stimulation of the clitoris, etc.? And so some of those conversations are so important because some people are, have in their mind that if they are having pain with insertion, with intercourse, that they can't be sexually active. And that's some of the education too, is learning. That's where a sex therapist comes into play, and learning the different options that are out there. We don't have to have this one idea in our head and think that you can't be sexually active.
That's great. Yeah.
What else is there to do for libido that's like not hormonal, not creams?
Yeah. So for libido, sex therapy, regular counseling, cognitive behavioral therapy. And, as far as those things go, we have a stigma sometimes about therapy, and also with doctors dismissing patients, especially women, with the, oh, it's in your head. That's, the term hysteria. That's, hyst is uterus. I mean, that's hysterectomy. That comes from hysteria, thinking women are crazy and all that, and dismissing patients. My thing that I'm always very clear with patients is you're a whole person. Mental health, physical health go together. So while I'm not going to say it's in your head, to say that there's no psychosocial component would also be not treating someone completely. And so those things, when I talk about sex therapy, counseling, cognitive behavioral therapy, those are such important components. And that doesn't mean it's all in your head, but it means that it plays a role. There's also other medications we have. There's a medication called Addyi, or flibanserin, which is, it's a prescription, and it's a daily oral medication you take, and it affects our receptors, the dopamine and norepinephrine receptors, as well as serotonin. And so dopamine and norepinephrine are excitatory. So those, if you think increase the sexual response, where serotonin can inhibit it, it affects both of those. It can improve desire, arousal, lubrication, orgasm, overall satisfaction. There's great data on it. And it can be used with other things. So if people are on other medications, there was some question initially when it came out as far as using it with alcohol. And so sometimes if someone's had a few more drinks, they'll skip a dose. But
is
that's
this like women's
medication.
Viagra? Or is this like the closest thing we'll ever get to Viagra?
So yes and no, because Viagra doesn't necessarily help as much with libido. It helps with arousal and orgasm. That's blood flow.
Okay.
So that's helping more with bringing the blood flow. And some women do use Viagra. But this is more helping with the actual, precursor, getting you to the point that you want that. So it's going to help. But it helps with all of it. And so we see good results. There's another one called, I can never pronounce the generic name, but Vyleesi is the trade name. That's an injection. And that one also works on dopamine, etc. I have no affiliation with any of these companies. That one I think is not as desirable because it is an injection. It's not a daily pill.
Yeah.
But
the things people will go through to have good sex.
Right.
Because sexual health is part of our overall
sex
health.
drive.
Yes, it is.
Right.
Of course. Yeah.
And we do dismiss it so often. And for men and women, it's like, oh, really? Like, okay, fine. So that's not working well, but you've got everything else. Well, but that's part of our lives, and that's part of, our health. Some other medications help kind of off-label. That's where the testosterone comes in, and we use testosterone in women. Bupropion or Wellbutrin affects dopamine and norepinephrine also. So there's some data for patients using bupropion to help with their libido, as well as another medication, Buspar, off-label. There's some data to say that it may help or not. So there are.
That's great. Speaking of men and women, because since you brought up men, can we talk about what's called menopause? Because now there's HRT, but it's for, what do they call it something else? It's testosterone replacement, so TR, right?
Right, TRT, testosterone replacement therapy.
And let's talk about the men. What's going on in them?
Yeah. So the men, menopause, I think that's just because menopause has become a big topic now. But I mean, to me as a urologist, I've been treating low testosterone in men longer than I've been treating women for this stuff. And so throughout men's lives, there are reasons why they may have low testosterone. But especially as men get older, they don't have the sudden declines like women do as much. There's more of this steady decline, and they absolutely can be affected by low testosterone. And so that's something to address. And when we talk about, couples, regardless of genders, if you have more than one person in a couple and one person's getting help with their symptoms and the other one is also having symptoms and not addressing it, that affects both of them.
Right.
And so oftentimes it's important to, that goes both ways. If we help a man, but yet if he has got a female partner and she has no interest or she has pain or whatever, that's great. He suddenly has great interest and he's got these great erections. But if he wants to be sexually active with his partner, we got to address her too, and vice versa.
What symptoms do men have? Like, we know all the women's symptoms because those seem to get discussed a lot, but the men's don't get discussed as often. What's happening for them?
They do and they don't. It's just in a different realm. Like I said, I've been addressing decreased testosterone with men for a long time. But so with men, we tend to see it can be decreased energy, decreased libido, decreased strength, trouble with weight, trouble with sleep, changes in mood. A lot of those same things that you can see affect on mental health, things like that. So there are a lot of things that we see with men as well. And depending on where they are in their years and other things in their lives will change how we treat that as well.
So is testosterone replacement, are there side effects to that? Is it safe?
It's very safe. There are risks. Absolutely. There are risks, and we always have to take that into consideration. One of the things that came up that a lot of people are, in my circles, people are aware of is there was a FDA roundtable looking at estrogen, because one of the things that prevented women from getting treatment was this FDA label that was a black box warning with all these risks for women with estrogen. And there was an FDA roundtable, and we actually got that removed. And it was successful, and it opens up access. Well, that also exists for testosterone. So testosterone currently is a Schedule III drug. Okay, so that's like narcotics. Like, you have to, have restrictions on how you can prescribe it and when the indications are and what the risks are. And, a lot of the stuff that's listed as risks, really the data doesn't support. And so while there are some risks, and we do have to be cognizant of those things, it's really much safer than some people think, and much safer than a lot of us in healthcare were even taught when we learned about it. And so there was an FDA roundtable more recently addressing that, and we haven't gotten the results of that one yet. We're waiting to hear what happens, but that also does restrict men from getting testosterone, and women.
Is there concern with abuse? Like, people are going to abuse it?
So that was one of the big things. There was this concern for abuse in weightlifters and bodybuilders and things like that. At one point there was a study that showed some effects on the heart. And that was, we're talking crazy, super physiologic, really, really, really high levels, not in therapeutic levels. And so most of the data actually show benefits, as far as heart health and things like that.
Okay. So with testosterone, if women take too much, doesn't your body change it into estrogen, convert it into estrogen?
So actually, yeah, that's, so testosterone does get converted to estrogen in fat cells. And so there are things that can affect that. But women we have testosterone. We have maybe a tenth of what men have, but it's important for women as well. And so we can use testosterone replacement safely. And again, same kind of ideas that if you use it within kind of physiological levels and not crazy high levels, you're going to see the benefits, and you're not going to have, people worry about acne and unwanted hair growth or hair loss on your head. And things like that. But, while those sometimes can happen, generally, when you use it within, therapeutic levels, we don't see as many side effects.
Okay.
All right, great.
What myths about menopause, since we're going to shift back, what myths about menopause do you wish would just disappear?
One of the biggest is the breast cancer risk, that people are so afraid because they've heard for so long that they can't use estrogen because of the risk of breast cancer. And it's very individualized, but even women who have breast cancer, some of them can use hormones, but especially patients who have family history. A lot of people say, oh no, I was told I can't ever use estrogen because my fill in the blank had breast cancer. And that's not true. Family history is not a contraindication to using hormones. And so there's a lot of women that just never get the information, and they never talk about it because of those myths that are out there.
Okay.
Although I will say one of my other ones that you asked for one, but I have more than one. But
okay.
One of them would be just this idea that we all want to be these great, strong women, and this idea of suffering through that, oh, I can deal with it. I'm tough. It's not about being tough. It's about, there's benefits beyond just treating the noticeable symptoms. There's benefits in hormones. We see improved cardiac health. We see decreased all-cause mortality. Like I said, there's some data for decreased risk of diabetes, decreased this data, which I'm hesitant to say, but as far as maybe even decreased breast cancer and other cancers. So, it's not this, badge of honor to say, well, I'm just toughing it out.
Right.
For men who are having symptoms, who do they talk to? Like, I feel like with women, it's so obvious, right? You have an OBGYN or whatever.
Dr. Brode.
Right.
Right.
Other than Dr. But
right.
For the regular man, like, does he talk to his regular doctor? Does he come see a urologist? Like, who does a man talk to about his hormones and sex
for
drive?
men and women, generally speaking, you start with your primary doctor. And as much as you say it's obvious for women, that's not always true. There's a lot of gynecologists that don't manage menopause. A lot of primary doctors that don't manage it. People wouldn't think a urologist is who you'd go to for menopause care, but yet there's so many of us now that are getting into that realm because nobody knew where to go. So for men and women, there are some primary care doctors that do enjoy doing it and do a great job with it and want to do it. And then there's others that are going to refer to a urologist or endocrinologist. And sometimes it depends on the community you're in. But I would always say start with your primary doctor. And if you can't get answers that way, then it's looking for a urologist and asking those questions and say, do you do this?
Okay. Thank you. I think that's important for people to know.
That is important, Staci. Thank you. Thank you.
Yeah.
So Dr. Brode, Staci has discussed her breast cancer. She's a breast cancer survivor. It was estrogen positive. And I'm thinking about all the Stacis out there who are hearing everyone say, yes, you could do hormone replacement. It's fine, and it's going to save you, and it's going to be great. What do you say to all the women out there who may not be able to take the hormones?
Right.
To help
that
them?
There's other options. And so, yes, maybe you don't get all the benefits that we have of using the hormones. But there's other medications we can use for symptoms too. You can use vaginal estrogen. One of my colleagues who specialize in breast cancer would send her patients to me for vaginal estrogen. So vaginal estrogen can be used. There are some breast cancer patients who can use estrogen, okay? But for those that really can't, we have other medications we can use. And so it's important that we discuss those options. And again, that's another one of those where some people just don't ever have the conversation because they think, oh, I have breast cancer, there's nothing I can do. But there are other things that we can do. There are other medications. And it is always a risk benefit. So while, yes, they may not get some of the benefits of being on estrogen, it's not worth the risks. And so we have other things we can do, and you're not left out in the desert with nothing, as a lot of women feel. They feel they're being ignored.
Well, good. I'm glad there's options.
Thank you.
Thank you. Okay. Is there anything else that you wanted to cover that we didn't cover?
There's so much.
I know.
I think my biggest thing is that there's options. Like you bring up, breast cancer, and you bring up men and women, and and all genders for that matter. That we have to have the discussions, and we have to talk about it, and people need to find a doctor that they're comfortable with. And that, I guess, is something that is important to me when you ask about who do you talk to, is you can have a doctor that is the top in their field, but if you don't have a good relationship with them and you're not comfortable having these conversations, you're not going to get the best care because you're not having the open conversations. And for me, one of my best compliments that I get from a patient is, I have to say, a lot of times from men, where at the end of a visit, they'll say, when I found out that you were a woman, I really was kind of worried about this appointment, and you made me feel so comfortable talking about something that could have been really embarrassing, and I really appreciate it. And like, to me,
that's wonderful.
I don't need to be the smartest in the world, but if I can have a good relationship with the patient so that we can tackle things, I think people need to look for that. When they're finding someone to take care of them, you don't have to have the biggest name or you have to have who you're comfortable with.
Right. Yes.
And it's not so easy to find, believe it or not, to find that. The people you connect with. Yeah, it's really important.
Okay. Now we'll get to the final questions. Thank you.
All right, good.
That was great. What is one takeaway, an action item that you would recommend our listeners do after hearing the episode today?
One takeaway would be talk about it. If you're not sure, talk about it. Talk to your doctor. Especially for those perimenopausal patients, they don't know that it's perimenopause. You just start noticing changes. Talk, ask the questions. It might not be. You might not want treatment, but talk to your doctor. I think that's the biggest thing. When I talk to physical therapists, I really believe in collaboration. So I talk a lot with physical therapists, regular therapists, sex therapists, etc. And I'll hear these things where, a physical therapist said to me how, like, my patient said that this, and this was happening, and their doctor didn't do anything. A lot of times my answer will be, did they even tell their doctor? Because when you have these short visits and you don't have time to talk, a lot of times their doctor's not managing it because their doctor doesn't even know it's a problem. Yeah. So talk to your doctor. They can't help you if you don't tell them.
Okay.
That's great advice.
If they don't know the answer to something, or you're not happy or comfortable with what they're saying, maybe find
someone else.
Get a referral for something.
Find someone else. Second opinions. I encourage second opinions. If you're worried or your doctor is going to be bothered by you getting another opinion, that in itself is a problem. My goal is to make someone better, not to help my ego.
Right, and that's great. Halle Berry tells a story about she went to her doctor. She'd been going to her doctor for years and years, and she loves him. She thought he was great. But she was having a ton of pain when she was urinating in the morning. Mm-hmm. And he said, I think it's herpes. And she freaked out, and it wasn't herpes. And then she goes, well, what is it? And he said, I don't know. So she had to go find a doctor who could help her. It was vaginal dryness, actually. She's very open about it, and I love what she's doing. But it's like she had to go find someone else, but she did, and it was fine. She still loves her doctor. But,
and to her doctor's credit, he said, I don't know.
Yeah.
So many people are afraid of I don't know. And I'm happy to say to someone, I don't know, but I'll find out, or I'll help you find someone that can find out.
Yeah, but you seem like the doctor that the doctors send their patients to know. So I wouldn't expect that you're going to get that a lot.
But I don't know everything, I don't claim to know everything. And that's why I say I encourage people, get another opinion, get another viewpoint.
That's great.
Why not?
All right. Our last question for you, Dr. Brode, is here at the Digestible Podcast, we like to say, don't panic, just pivot. Is there a recent pivot or change you've made in your life that you're proud of that you're willing to share with us?
Well, for me, I started my own practice. So, and it was, if you want to do something, sometimes it's scary, but you can do hard things and do it. Doesn't matter where you are, what stage of life, do it. Take the leap.
Love it.
You can do hard things.
You can do hard things. Thank you so much for your time today. This has been amazing.
Thank you. I love it. It's great. I appreciate it.
Thank you for listening to the Digestible Podcast with today's guest, Dr. Amy Brode, who you can find at thebalancepointwellness.com. If you like today's episode, please share us with others. It's the best compliment you can give us. If you have any questions, comments, or ideas, please feel free to email us at info@digestiblestrategies.com. We look forward to hearing from you, and remember, don't panic, just pivot. The content shared on this podcast is for informational and entertainment purposes only. We are not medical professionals, and the views expressed here are not intended to diagnose, treat, or cure any health conditions. Always consult with a qualified healthcare provider before making any health-related decisions.